the Medical AI Podcast.
Hello, and welcome to the Medical AI Podcast, a 30-minute thrill ride of big ideas. We are Dr. Felix Beecher and Joe McKeating, and we talk to a range of top guests, from scientists to industry innovators to philosophers. The liver is a miracle of physiology with over 1,000 known functions. This highlights the potential impact of liver dysfunction on various bodily systems. Also, liver disease is a major cause of death globally, and the numbers are on the rise. This adds up to a critical clinical need. Dr. Neil Guha is a Professor of Hepatology at the University of Nottingham, an NHS consultant and a research scientist. He recently published an excellent paper in the Journal of Medical AI on a machine learning model to rate risk for liver disease. Neil, I am absolutely thrilled to have you on the podcast. A very, very warm welcome.
Thank you, Felix. Pleasure to be here.
Great. So, could you just introduce yourself, talk about your work a little bit, and explain about your research?
Yeah, so my name's Neil Guha. I'm a professor of hepatology at the University of Nottingham, and I'm based at the NIHR Biomedical Research Centre. And essentially, I spent 50% of my time doing clinical research and 50% of my time looking after patients with liver disease in the NHS.
Fantastic. Okay, so let's turn to this paper that you recently published in the Journal of Medical AI. Let's start off with the basics. Could you explain what the problem is that you're trying to solve here?
Yeah, so I suppose there are three major issues. The first is patients with liver disease present late. 50% of cases of severe liver disease present after an emergency. Um, and the second issue is because it's asymptomatic until quite a late stage, the traditional tests that we use, some of the normal blood tests, aren't very good. They sort of lack sensitivity, and what we mean by that is they don't pick up those with the disease, and they also lack specificity, which means that even if the test is positive, those that we go on to test with other more accurate tests don't show up that positivity. And the final aspect is although liver disease, as you alluded to in the introduction, is quite common, the liver is the only solid organ in the body that can regenerate. But we have to pick it up at a critical stage and intervene at an appropriate time in the natural history. So essentially, my program of work for more than 20 years is to try and find better tests to detect liver disease, which eventually will hopefully improve the outcomes for patients and the wider health economy.
Okay, so liver disease encompasses a few different types. Could you talk about that a little bit?
Yeah, so we sort of break down liver disease into, things that cause an acute issue and chronic issue. And I suppose there are three main things that cause liver disease across the world. Those are viruses, particularly chronic hepatitis B and hepatitis C, and then alcohol, and then what we call metabolic liver disease, things associated with obesity and type 2 diabetes. And in the UK, I suppose the biggest drivers of liver disease in the UK are alcohol and the metabolic liver disease faction.
Um, okay, so you've talked a little bit there. I mean, you could just slightly dipped your toe into the causes of liver disease. Could you talk a bit more about those and why prevalence is on the rise?
Yeah, so unfortunately, alcohol rates or hazardous alcohol in the UK has always been high. In contrast to other parts of Western Europe where alcohol rates have actually fallen. So sadly, that still is the commonest cause of liver disease that we see in the sort of emergency setting on the wards and so forth. The other group of diseases, the sort of metabolic liver disease, is related to diabetes and obesity. And unfortunately, obesity rates in the UK and the Western world are rising. So interestingly, both conditions cause problems in a similar way. So if you look at the liver under the microscope, what you'd see is initially sort of fats in the liver, but that then it gets associated with what we call inflammation, and that then gets associated with scar tissue, what we call fibrosis, and eventually that scar tissue builds up. And the liver starts to fail, and that's when clinical symptoms ensue.
And what about treatment? What are the main treatments for liver disease and how successful are those treatments?
Yeah, so that's a good question, really. The most important treatment is to get rid of whatever's causing the chronic damage to the liver. So if this is a virus, for example, we can now get rid of the virus. We've essentially got a treatment for hepatitis C, for example, which is able to get rid of the virus, with oral tablets in approximately, almost reaching 100%. For alcohol, as you can imagine, it's simply stopping drinking, and if we can do that, if we can encourage our patients to do that and support them to do that, the liver can regenerate, within 6 months to a year's time. Um, Obesity is more difficult. Again, it's about removing the insults, whether that be, well, of course, losing weight and lifestyle factors such as that improve scarring of the liver tissue. We don't have what we call an anti-fibrotic treatment for liver disease. As a licensed treatment, there are a lot of exciting prospects coming along now in clinical trials. And interestingly, one of the barriers to the area to developing new treatments is the lack of diagnostics. So it all sort of fits in together, really. We need to find these patients earlier. We need better diagnostic tests that will identify the group of patients, but also help us to develop new treatments.
And how much of a difference does the timing mean? I mean, if you catch disease, but it's in the late stages, is that really critical, or is it actually a fairly modest difference?
Yeah, that's a pertinent point, Felix. So, often when I'm on the wards, we can sometimes see people who present very, very late in what we call the sort of decompensated state, where the liver is failing, they're yellow in their eyes, they might have fluid in their tummy, something we call ascites. And those patients are really difficult to treat because they are at such a late stage. Sometimes, things will improve slowly, but they're prone to sort of life-threatening complications. And then, of course, we may only have the option of something called liver transplantation. And liver transplantation is a big operation. It has risks to health, and of course, there's a resource issue. So, for example, in the UK, depending on what figures you look at, between 16,000 to 30,000 patients may die from liver disease, but we only transplant 1,000 organs, liver organs a year. So you can see what the shortfall there is.
Yeah. Okay. Well, we're almost, I think, at your paper. So let's think about what there is already in terms of early diagnostics. What does the landscape look like there?
Yeah, so if I take you back to sort of 10 years ago when we started doing this, we got a little bit frustrated in Nottingham, sort of, waiting for patients to come, through the system and present using the normal pathways. So we developed a project called the Scarred Liver Project, and we thought, well, why don't we find patients who have identifiable risk factors, i.e., alcohol, or metabolic risk factors in their GP surgery from their GP records, and then directly approach those patients and offer them a sort of evolving test and something called FibroScan, and that was a what we call a non-invasive test of scarring. And the FibroScan essentially sends a wave across the liver, and if the liver is scarred, that wave goes very quickly, and we can convert that into something called kilopascals, and those kilopascals are related to how much fibrosis or scarring in there. So that was quite a successful project. We looked at almost 25,000 patients across Nottinghamshire. We were able to identify liver disease earlier at different stages. And if you look at the most sort of significant liver disease, we increased the diagnosis of liver disease by almost twofold. So that was our starting point. And then there are other, you asked about other tests. You can do sort of more, fibrosis tests using blood tests and so forth. You can use MRI imaging. But we thought the FibroScan was quite a useful test. The problem is there's a lot of people with risk factors. Almost a third of the population have risk factors for liver disease. So the capacity issues of being able to scan the whole population become quite challenging. So we had an opportunity about 3 years ago, in 2020. Someone called Professor Neil Hanley at the University of Manchester created a consortium with the Nottingham and Manchester, the two academic institutions, and about more than seven other industrial partners to try and improve the diagnosis of liver disease. And one of the work streams in that project was, could we use artificial intelligence to try and improve diagnostic algorithms in a community setting, and specifically reduce the number of people who could need a FibroScan without losing accuracy. So we were able to sort of curate the previous research to start to develop these AI algorithms. And specifically, we worked with a private company called Jiva, and one of their founders called Manish Patel, and his group of data scientists to develop novel AI algorithms.
So, I mean, this is one kind of AI that I really love when you're using very readily available, cheap and dirty data, but managing nonetheless to do something very meaningful with it, right?
That's correct. And you asked about tests, and tests can be from very using very simple data all the way to specialist fibrosis markers. They can be proteomics, metabolomics, all these omics technologies is where it could go. But we wanted to ask the question that, could we use, as you say, that readily available data that's already been collected as part of routine care to do something different with it? And that was our
Yeah.
starting point.
Okay, great. I mean, it's not only quick and easy and easily deployed in principle, at least, it's cheap for the taxpayer, of course, right?
That's right, because that data has already been
Yeah,
collecting. So for the paper, for example, we looked at, 87 variables
yeah.
which had already been collected as part of that patient's routine care. So some of them included blood tests, some of them included, their weight, what we would call their socio-ethnic characteristics. We collected medications. We just took everything that we had on those patients to sort of
Yeah.
to put into the algorithm.
So now your outcome measure, your ground truth is the FibroScan, the ultrasound FibroScan. Now, is obviously when you have a ground truth, you want it to be as truthful as possible, right? So now, how confident are you that the FibroScan was giving you a ground truth that was solid?
Yeah, so that's a good point. So the ground truth in liver disease is actually to wait for a liver, what we call a liver related outcome. Okay, so that's a liver clinical event, but that would take 15 to 20 years. And I don't think I'd be practicing in 15 to 20 years, so we can't wait that long. So the second ground truth that we often used historically in liver disease is called a liver biopsy, where we put a small needle into the liver and look at it at a microscope. And you can imagine, your listeners can imagine, well, that's not a very practical thing to do in a community study, and you could argue whether that's even ethical. So the FibroScan is a surrogate of those two outcome measures that I've talked about. And actually, for very severe liver disease and cirrhosis, it's quite good. It's very good, in fact. It's very accurate. But and at the level that we wanted to do, which was not missing any disease, this sort of, the absence of significant fibrosis, again, it's very good. So there's some caveats to using FibroScan, but we specifically chose a reading of around 8 kilopascals to try and make sure that we weren't missing people without the confidence. And as I said, the real aim was to reduce the number of scans that the population would need to have.
And let's talk about the predictor variables as well. What kind of predictor variables did you input into the model?
So the predictive variables came from those 87 variables that I talked
Yeah.
about. So they came from, we call them basic demographic
Mhm.
um, data. We looked at things like simple blood tests, so your full blood count, your liver blood tests, glucose measurements. So of those 87, we found that eight had the biggest
Yeah.
impact on the on the algorithm. And to be fair, they were mainly consistent of what we call liver blood tests, but there were some other things that platelet count and lipid levels were also in there. But some of those tests weren't a surprise. But of course, what the AI algorithm does is it combines them in a unique
Yeah.
fashion. And that really is what gives it its sort of novelty.
So, was there any way in which the results made you think hard about what um, the most predictive variables, what the meaning of the most predictive variables were? Like, for example, did you kind of think to yourself something like, well, why would platelets have anything to do with liver disease? Well, let's really think really hard about that. Did it kind of teach you anything about the, I don't know, the biological mechanisms here?
Yeah, so this is a really interesting question. So, um, because of course, if you have a predict, what we really want sometimes is we want predictors that also act as insights into mechanism. And in truth, we didn't get that. Um, but what we got is what I would say some old friends who'd been neglected. We all thought, well, that marker isn't that quite good. Sort of reared their head again. So I think it did take us back. And opened our eyes to some of these things that we just discarded. Actually, if used properly and combined, could be quite useful. Um, but if it was but one of the things I think that people are quite interested about AI, and we haven't done it in this project, is could it open up novel insights
Yeah.
into mechanistic pathways? I think that's a really interesting point.
So could you just briefly describe what kind of strategy you had for developing the model? What kind of algorithms did you test and so forth?
Yeah, so the data was first of all split into what we call a training data set and a holdout data set. And what that means is that we took two-thirds of the data set. We tested about 9 different machine learning models on that, things like forest classifiers, logistic regression, and so forth. And the details of that are in the paper, and I'm sure there's some data scientists on the podcast who'd be interested in that. But we tested all of those head to head in that training data set. And there's a sort of bit of where it sort of gets it gets tested and retested on small subgroups of that cohort. But then what we do is we took the most promising machine learning model from that, and we tested it on an unseen
Yeah.
data set. And that sort of gave us the confidence that the model was robust, because otherwise, you're always in this slight quandary about how robust is the model.
Sure. Okay. Well, could you summarize, Neil, the accuracy of the model that you developed, and could maybe include something about the false positive rate and the false negative rate?
Yeah. So when we do develop diagnostic tests, we use something called area under the curve.
Mhm.
Actually, it's a diagnostic accuracy test that I think originated from World War II, when they
That's
were
right.
trying to
Radar, was it? Yes, that's
radar.
right.
That's right. That's how AUC was developed. So it's interesting how how things develop. So to the uninitiated, an AUC of 1 means you have a perfect diagnostic test. An AUC of zero point 0.5 basically means you're sort of flipping a coin. So you want it closer to 1 as possible. And really, really good test is around zero point 0.8. Our test came out above zero point 0.7. And if you compare that to one of the other comparator tests that we did right at the end of the study, that was zero point 0.5. So it was superior. But in terms of what you asked, it sort of was better at not missing those with disease. So it had a better
Hmm.
sensitivity. And for that, so its false negative rate was better. And that's really important, because what you don't want the ML algorithm or any algorithm in the community to miss is those who may have significant
Yeah.
disease, who then get falsely reassured. Now, of course, if you have false positives, it might mean that they go and have unnecessary investigations. That's not ideal, but that's the balance
Yeah.
that you have to have. So so that's the sort of trade-off that we say in diagnostics between this sort of not missing disease versus not having too many false positives.
Okay, fantastic. Well, and congratulations on such a nice paper. How would this potentially change the status quo? Does it potentially represent a significant advance?
Yeah, so I think, as researchers, we are always sitting there and going, how will it have an impact? So let's go forward and then probably come back. Where do I see this will have an impact in three aspects, I suspect. First of all, if we can develop this as a population tool, it could have a major impact on workforce. Specialists like myself in liver disease, it takes a long time to train us. There's not that many of us around, comparatively to the nature of the disease. So, and GPs, on the other hand, are enormously busy. They're time poor and they're expected to have expertise in many areas. So, in terms of the workforce application, both for specialists and GPs, immense. The second aspect is improving inequity. It's sort of identifying the right people at the right time. And a lot of people with liver disease are in disadvantaged settings. They may not have the same access. So if you had a population health tool that could identify them, so you could go and seek those patients, that sort of makes more sense. And the third aspect is the tools themselves could help facilitate better infrastructure for the community management of liver disease. So a lot of these things are, things like lifestyle condition, and they might be associated with heart disease and diabetes. And part of the NHS long-term plan is to try and move, specialist care out into the community. So using population tools like this, we might be able to identify those people, but also create better infrastructure where not only we improve their liver related health, but their heart conditions and their diabetes. So this is future
Yeah.
forecasting, but that's where tools like this could really come and be a game changer.
Okay, great. So what you've done then is something magnificent. You have established a proof of concept for this machine learning system. But of course, what really counts ultimately is what happens in the real world in clinical practice. So what's standing between where we are right now and the rollout of this kind of system into clinical practice?
Yeah, it's a great question, isn't it? So the pipeline, I think has different parts to it. The first set from a clinical researcher is clinical validation. So we've done this in Nottingham, but so does it still hold in other areas? So we're collaborating with our colleagues in Manchester, Neil Hanley's team, someone called Verinder Atwell, who's a consultant hepatologist in Manchester. We're trying to test that in that population, and they sort of co-designed that with us. But we'll be able to see how that algorithm performs in a population from Greater Manchester. In fact, some of that data we've looked at, and it looks really promising, and we hope to have that out as a separate publication in the next year. And then, of course, AI isn't just, one of the issues about AI data sets is you need to do it on multiple data sets, which have been really well
Yeah,
phenotyped. And we might not just need to do that in the UK, we might need to do that in international settings.
I
But
see.
once we've got clinical validation, of course, we need to get approvals. We needed to get it, the digital device registered under MHRA. We need to get NICE approval, and that's showing it as a clinical effectiveness and more importantly, cost effectiveness, particularly for the NHS. And then the final bit is really implementation. How do you get the tools integrated and used within the
Yeah,
NHS, which could be quite difficult. And I'm going to be very honest here. We do a lot of research. The one of the challenges is it's often said that the NHS, it takes 17 years from research to get involved, and
Yeah,
and you can
that's one of the most
involved in care.
depressing statistics I've ever heard.
Exactly. And just telling you all these steps, that there are a lot, and rightly so, there are very important regulations, but they take time. And so one of the things my colleagues, Manish Patel, who's at Jiva, and Neil Hanley and Verinda and myself have been discussing, is that it might, one way to facilitate this is to have a spin out company that is then able to dedicate time and resource to going through all these regulatory hurdles, because otherwise busy people just
Yeah,
don't have the time and energy to do that, and that's a real challenge, I have to say. And when people get frustrated, they have to realize that that's what, this takes both time and
yeah.
money. And the NHS is a wonderful place to do research, but it's also quite a frustrating place to do research. And I was talking to, Manish Patel from Jiva, and he was telling me, he sometimes, he hasn't got much hair, but he does pull his hair out, all the different steps, all the different hurdles. And, sometimes you have to go and do that work in different countries and then come back. So that's just a very honest
Yeah.
opinion of all the steps that we need to take. I'm really hoping it's not going to take 17 years, but it won't be next week either.
Right. Okay. Well, look, Neil, why don't we turn to a couple of general issues that I know you're interested in? And we briefly mentioned false positives and false negatives. And of course, that leads us on to the question of litigation potentially, right? Because if somebody is treated, for example, for a disease they don't have, then they might well be within their rights and of the mind to sue. So when it comes to an AI system that's maybe made that decision without any human input, how does that kind of issue get addressed? Do you think?
Yeah, it's a really, really interesting question, isn't it? I went to a new scientist AI conference with my son, and a lot of the really interesting debates were about the ethics, weren't they? About AI rather than the nuts and bolts. And so you're right. I think all of these systems need human overlay, right? So I think at the moment, if I, as a doctor, want to use an AI system, I think the responsibility lies within me and my
Hmm.
organization. But once you start deploying that on a population level, right, then I think there's a really interesting question of when things go wrong. So, is it the AI manufacturer? Is it the developers of the tool? Is it the people that actually deploy the tool in the practice? On a a sort of local health ecosystem. And I'm not convinced that's been totally answered. I think it's generating a lot of debate. So the simple answer is, as it comes in, I think there'll be individual responsibility, but as the system becomes, more widely used, that area becomes a little bit grey, doesn't it?
Okay, well let's discuss a second issue, and that is about culture within the medical profession and maybe within the NHS as well. How do you is there could you describe what the kind of cultural center of gravity is as it relates to AI systems for medical purposes?
Yeah. Well, if there are any doctors listening to this story, they'll like this, because using IT in the NHS is one of the most frustrating things in the world. It takes, we've got computer systems that I don't think you'd be allowed to use in primary schools. It takes me 15 to 20 minutes sometimes to boot up a computer. As various things. It's really, really clunky. The IT systems are often outdated, they aren't joined up, and that causes real frustration. So the thought of having an AI system on board, I think, makes a lot of doctors almost laugh. But actually, sometimes you need, a real radical change in technology. For things to change and for that investment to come, and the investment in IT in the NHS is has been poor, and that, quite frankly, needs to
Right.
change. But in terms of the AI, I think it's really interesting. So for me, the real debate going forward is not just about the accuracy of the tools and information governance and protecting people's data, but how doctors interact with the
Mhm.
AI tools, because it's just ultimately another piece of equipment, and we need to think of start training our doctors coming through medical school, our junior doctors, and even the more senior consultants like myself about understanding, the bias in AI systems, the sort of limitations, but also the potential. And I think that debate is quite immature. People either think this is going to be a savior or the devil's work, and that sort of polarized view isn't that
Yeah.
useful. Personally, it won't become as a surprise to you. I wouldn't be doing the research in the area if I think it's gonna be a real shift in how we practice
Yeah.
medicine. But I don't know what that timescale is, and it all could happen quite quickly.
Okay, wonderful. Well, look, Neil, you have given a fantastic summary of your research and also these general issues that we've just discussed. So thank you so much for that. There's one question which I always ask at the end, and that is, what is your favorite current example of medical AI that's got nothing to do with your own research?
Okay. Um, so one of the things that if you ask doctors about why an AI will never be able to replace doctors, they quite reasonably answer, well, you'll never be able to get the empathy from an AI, and that's something I've thought for many years, and I still think, quite frankly. But there was a paper in JAMA of internal medicine that came out last year, which sort of superficially challenged that. So what they did is, using a US social media platform, Reddit, where members of the public can put in medical queries onto this platform. And usually health professionals answer, and all the health professionals are vetted, and they give the answers. So some cunning researchers thought, well, why don't we test ChatGPT's response and compare it head to head with these medical professionals? So they took about 200 of these queries from the public. And then they got the responses from, the healthcare professionals, and then asked ChatGPT what the responses were. They then blinded it and then showed another panel of medical practitioners, all experienced clinicians, and they asked them to rate the responses in two major categories: the quality of response and the empathy. So the quality of the response, the medical raters rated ChatGPT had a better quality of response, which was the first surprise. The second surprise is they thought the ChatGPT response was more empathetic, which was actually quite amusing. And of course, part of that because the ChatGPT response was a bit longer, it's a bit more detailed. It doesn't get tired and it doesn't get curt or hungry. So I it's a slightly artificial setting. It's simple queries rather than complex queries. But I think it's just an interesting aspect of all of this is up for research, isn't it? What do we mean by empathy, and what
Yeah.
we when we say throwaway comments like it'll never be as empathetic as us? Well, it depends on the context, right?
I'm
And
not
so
completely surprised because I think that large language models, on the whole, can be nauseatingly empathetic and sensitive, almost as a flaw.
I suppose you're right. And if they're empathetic but they're wrong, then there's a real problem with that. So we have to be careful that it's balanced. So
Yeah,
the accuracy is right. But then you can imagine, particularly in America, there are
yeah,
so many queries that physicians get. And that takes time and resource. So some of those low-lying queries, if they can be taken up by an AI, answered at the first triage level by an AI algorithm, and then of course you still need human
yeah,
oversight. Could that save manpower? Could that actually stop the sort of huge epidemic of burnout that we're seeing
yeah,
both in the States and the UK? So that needs to be explored, and it's a thought and an interesting debate. But that paper really tickled me, and really
yeah.
I presented at our local journal club, and it caused an enormous amount of debate, as you can imagine.
Quite. I mean, this, because it's research. These are clinicians on their best behaviour as well, right? This is this is not when they're tired and grumpy. This is them trying to be their best selves. It's
Absolutely.
fascinating. Neil, thank you so much. I think you've given a magnificent account. So well done, and would be great to have you back sometime.
Thank you very much,
Right.
Felix. I hope that's was useful, and great chatting to you.
Cheers, Neil. Thank you for listening. This has been the Medical AI Podcast. We are Felix Beecher and Joe McKeating. Ping us on LinkedIn if you have any ideas on new guests. See you next time.